Heather, go ahead and start also admitting people, then I can switch screens.
Okay, yeah, I'll do that.
Okay, let's go ahead and do the roll call. Commissioner Cruz? Commissioner Cruz? Commissioner Mazziotti? Don? Don, can you hear me? I heard you earlier. Can anybody hear me?
I can hear you. Yeah.
Okay.
I don't see his phone number anymore, so he'll probably come back on.
Okay. Man, I cannot wait till we're in person. All right, sorry, let me go back to the screen that has the list. Okay. Holton, Commissioner Holton, Dwight, Commissioner Archer,
Present.
Commissioner Huppy,
Present.
Minty Morris,
Hi, everyone present, and I second that. I can't wait till we're all in person so I can meet you all in person.
Commissioner Godwin, Commissioner Godwin, Commissioner Neeson is excused. Vice Chair Golliran.
I am here.
Thank you, sir. Commissioner Clarkson.
I'm here. Hi.
Chair Tony, we got you.
I think Dawn may have just come back in.
Thank you. Don, are
Sorry.
you on the call?
Yes, can you hear me?
Yes, we can hear you. Great. Welcome back.
Thank you.
Commissioner
I
Nordijk.
apologize, I'm on the phone.
No worries. Commissioner Nordijk,
Present.
welcome. Commissioner Obiera,
Present.
thank you. Welcome. Senator Solomon. Or someone from
Present.
Senator Solomon's office.
Yes, present.
Who's that?
Oh, this is Senator Solomon.
I didn't
Janine.
recognize your voice. Thank you. Judge Block? Judge Block?
You're muted.
Sorry, I was on mute. I'm present. Good afternoon,
Thank
everyone.
you. Thank you. Director Allen. No, I'm not sure if he's back from vacation. So. Tony Biglin. Dr. Biglin. Okay, Chair, we have a quorum.
Okay. Thank you, Dr. Richardson, and thanks everybody who's here today. We are a little ahead of schedule, but we'll probably just get into our first agenda item. I do want to say that I want to thank the other commissioners who took the time to meet with me individually to just kind of chop it up and talk about how it's going and your engagement with the commission. Some of you guys I emailed and didn't hear anything back from. I'll email you again. I know everybody's busy and it's no requirement, but would love to meet just one-on-one, get to know each other more, and just talk about the commission's work and be helpful to you in any way that I can as the chair. So look for another email from me. If you're good to go, John and Jen, we could kick it off a little bit early. I just want to kind of orient everybody that unfortunately this type of presentation is all too regular, and it's something that I've worked on a lot over the years with individuals. So really glad that we had a quorum here today to listen to these two community members discuss their stories and come to us with their vulnerability and their courage and their strength. So I will pass it off to you two, and just let me know if you need anything during the facilitation process. I will give you a kind of a 5-minute warning if the presentation's running long, so we leave some time for discussion, okay?
I think you are muted.
Yeah, y'all are muted.
How's that? All right. You'd think this far into the pandemic, we'd have that figured out, but seemingly not. Thanks, Tony, and thank you, Dr. Richardson, for the opportunity to be here today. We're really grateful, and just want to recognize that. Finish getting this up. Want to recognize that we come here as community members, as Tony said, with a story to tell. And we're humbled by the amount of expertise and commitment in the room here. Don't think that we necessarily know things better than anyone else. Mentors and leaders along the way have encouraged us to continue to share our story so that people can, in your position, can have a good understanding of what we're seeing. So that's what we hope to do. And it also shouldn't go without note that we don't feel like our story and the topic that we're covering in any way is more important or should be a higher priority or any other words you want to use that somehow puts our story above anyone else's story of the 1,000 people we lost last year to drug overdose and poisoning in Oregon, people struggling with long-term addiction, substance use. We are one aspect of this bigger complex situation, but we feel like telling our story is important, so that's what we're here to do. Before I get into it, Tony, can you just give me a verbal whether you can see the screen as the way you should?
Yeah, you're good to go.
Yeah. And I just want to add to that, not only is our story, not unique and we recognize what everybody is doing is important, but we believe that awareness is a part of a much bigger effort that needs to happen. So, what we're trying to do is, in terms of raising awareness is a part of the puzzle, and there's a lot that needs to be done, and we respect everything else everybody else is doing as well.
So with that said, we'll get into it. So I want to, just click off on these top 4 points that cover what's in here. There is a shift underway in overdose and poisoning age demographics nationally and in Oregon, leaning towards youth. And it's fueled by the synthetic drug landscape and the way that landscape is changing. There's a combination of factors, importantly, beyond just the velocity and the toxicity of the supply. That includes the nature, something new, which is the counterfeiting and the deceptive nature of it, as well as the normalization of pill use as a low stigma self-medication or recreation sort of thing for our youth. And all of this is happening in the midst of a long-term youth mental health care crisis, as you know. And I heard somebody use this word the other day, a syndemic, which is epidemic on top of epidemic, sort of feeding each other in some ways. Oregon is one of the most impacted states in this problem. And we have found and noticed that the mitigations needed for this aspect of the problem are beyond our traditional back-end focused, meaning sort of past, into treatment and recovery. Beyond those focused approaches are needed because of the speed of the synthetic drug landscape change, the impacts it has and the different user base that's involved. So what I want to do is briefly take you through a national arc of this story. We work with a national nonprofit called Song for Charlie that we joined since the death of our son. We'll briefly cover Cal's story. I appreciate the opportunity to have sent out the video that Beaverton School District made with us. If you haven't had a chance to watch it, please do. It's in your email, because we're not going to go into all of those details here. But go a little bit into our personal story, what happened with our son, share with you what we've learned in our journey in the year and a half since he passed, working locally and nationally, and then get into some specifics in Oregon. And finally, we have a page with Tony's guidance. I've sort of tried to tailor this in a way that half of this presentation can be some things that we are asking for or are questioning whether these things could happen, and wanted to make sure there's room for discussion on those things. I have worked in the corporate world for over 30 years, analyzing data, finding insights that enable action. And when you see information that looks like this, it is evident that there is something new that's happening and action is needed. The challenge with small numbers and groups like our youth that proportionally or relatively die far less than the rest of the population is sometimes it's overlooked. And that's why we look at growth. You know, very short anecdote in working at Nike. You better believe that Nike was looking at the growth of Lululemon well before Lululemon started to take significant and material market share from Nike. So you need to look at the small numbers and how they're growing in order to take action before they become much larger numbers. The annual growth rate for drug overdose and death for the whole population has been about 8% over 20 years. For youth, it's a little bit less, 6 or 7%. 2020 was an absolutely horrific year for everybody. Total overdose and poisonings up 30%, driven by fentanyl, which was up 55%. As you know, it was like 93,000. It's over 100,000 now. People nationally passing away. And for youth in particular, it was really, really bad. Our teenagers in high school, the death rates for 14 to 18-year-olds doubled in 1 year. In fact, the 14 to 18-year-olds had the highest recorded 1-year growth rate across all 5-year age groups across 20 years. So it was a horrific year, and it was driven by fentanyl. And one of the reasons that we found that this is affecting youth more than other ages or disproportionately is the knowledge gap. Now, the Monitoring the Future survey and other surveys nationally that measure risk perception or harm perception, they don't ask questions yet that get to what do you think the risk is of taking a prescription opioid off script and with the possibility that you might get fentanyl. They don't ask the question that way, so we really don't know from that standpoint. But we engaged with some partners in the high-tech industry, and they in turn they did some surveying with Morning Consult in a statistically sound way that got to these insights. So our kids are stressed, and it's real. And they cite their stress as a common reason to misuse prescription medicine. But a third of them don't know what fentanyl is, and 3/4 of them had never heard of fentanyl and counterfeit pills. Further, when asked to rate the relative harm or how dangerous these substances were, the survey found that the same number that listed cigarettes and roughly prescription opioids as extremely dangerous rated fentanyl in the same space. So they think fentanyl, if they know what it is as dangerous as cigarettes. Yet they're dying from it at 14 times the rate they are from heroin, because there is an inconsistent and often powerful dose that's deceptively sold inside counterfeit pills as a Xanax, Oxy, Percocet, etc.
So as John said, the victims of the opioid epidemic are now starting to become younger and younger. And sadly, our son Cal falls into that category of victims. I will try not to spend too much time on this because hopefully most of you saw the video already, but Cal, was a typical teen, we thought. He was very involved in school. He always held a job from the time he was 15. He had jobs as lifeguards, swim instructors at the grocery store. He got good grades, maintained a 3.5 grade point average, had lots of friends. Seemed to have a good life, did not come from a high risk family. Socioeconomically, you would not have thought he was a high risk. He came from a family where divorce wasn't a factor, etc. We did know at the beginning of the senior year, we found out that he was using some marijuana. We had discussions about that, said it was not appropriate in our family. Got some training on that with him. Later in the year, we realized that he was dealing with a lot more anxiety issues than we realized. And he said he was using marijuana to help stimulate his appetite. So he, we learned that he had an eating disorder, got professional help, which was a challenge in itself and could go on about that. But got professional help, was seeing psychiatrists and counselor. And basically, we decided that he seemed to be doing well. He really wanted to go off to school, and after consulting with his healthcare experts, decided that was the best thing for him. So we sent him off to University of Hawaii for his freshman year, and came home at Christmas time. And within a couple of days of coming home, we found him unresponsive in his bed, and called 911. Paramedics came, John did CPR. We got him to the hospital, but he never came around again, and we had to say our goodbyes. A few months after he passed, doing searches on his phone, we learned that the day before he died, he had done searches on Google, and he Googled Oxycontin, Oxy, and he was trying to find the appropriate dosage for his weight. And he was also looking up how it would react with his anxiety medicine. So we don't condone the choice that he made to take a pill and to self-medicate. However, he was trying to be safe. He did not want to die. He was doing the best he can with his 18-year-old brain. So next. Since losing Cal, we have found that we are by far not the only family who have experienced this problem. Within Oregon, we have met dozens of families who have lost kids, many of them teenagers. Across the nation, we have met hundreds of families who are sharing our story. And with the introduction of fentanyl and synthetic opioids into the drug supply, and with the cartels deceiving people and putting them into pills that look exactly like pharmaceuticals, the victims are getting younger and naive, and often they're dying sometimes with their first pill or in their first experiences experimenting with these drugs. So these victims, it's no longer just the high risk kids or the high risk people that are dying. It covers all backgrounds, any color, any socioeconomic background, boys, girls. It is changing what the victim looks like. And with fentanyl and synthetic opioids, it is giving families and friends and perhaps even kids fewer chances to intervene. There's stories of kids who are dying on their first pill or half a pill. Often families don't see symptoms or the traditional signs of drug abuse before the victims are dying.
Thanks, Jen. So this is the last page before we get to the page with the discussion. And I wanted to bring it home with what's going on in Oregon. And my apologies for those of you who prefer charts or graphs and things. I have those in the backup, which you should have a copy of that deck if that's better for you. But there were just too many, and I wanted to try to keep it short. And I will steer you through how to read this. These are data that I pulled from the CDC, and it's for the 12 months ending June of 21. So from right after the COVID epidemic and lockdown started until halfway through last year. The first box I want to draw your attention to is at the top, where you have that United States 28.7. That's the death rate in the US for all drugs during that 12-month period. And you'll notice that Oregon, 21, right underneath it, is significantly below the national death rate from substances. Similarly, for fentanyl, the US death rate is 19 per 100,000, and in Oregon is below 9. As you know, Oregon has a meth challenge as well. But Oregon's doing relatively well against the rest of the country when you look at it at that level. When you look at the growth statistics, however, remembering back to that first graph that I showed you, notice that Oregon is growing in overdose death rates at twice the growth rate of the United States, 46% versus 22, and for fentanyl at 5 times the national rate, 153%, which is first in the country during this time period for fentanyl death. So worst in the whole country for the growth of fentanyl death is in Oregon, 5 times worse than the national rate. Now, when you click that down further into 15 and 24-year-olds, you'll notice first in the top table that for the US age 15 to 24-year-olds, the national rate is 13.9 for fentanyl. In Oregon, if you go now to the bottom left table for 15 to 24-year-olds, the death rate for fentanyl for youth is 14.8. So Oregon exceeds the national death rate for fentanyl-involved deaths by a little bit. And the growth rate in Oregon for that is 118%, which is higher than all other age groups. And the share of fentanyl involved in those kids and young adults' death rates is 77%. And as you can see, if you look vertically down the vertical fentanyl share column, 15 to 24-year-olds are more impacted by fentanyl than all the other age groups. So they're not at the bottom, but they're, I think, second or third in the death rate for fentanyl, and at the top of the how much are their deaths affected by fentanyl. And when you go over to the right, the last chart, the one on the right, for CMW counties, that's Portland, Clackamas, Multnomah, and Washington County, you can see that actually 15 to 24-year-olds are dying from fentanyl at a higher rate than all the other age groups. So we're past the growth stage in Portland, and youth are dying from fentanyl at higher rates than all the other ages. And that's growing at 111%, so it's doubling. And the fentanyl share in Portland area for 15 to 24-year-olds is 84%, or 32 out of 38 teens and young adults in this 12-month period died with fentanyl involved. So it is disproportionately impacting Oregon, and it's disproportionately impacting our kids in Oregon. And even though the numbers are smaller compared to the total number of drug overdoses and deaths, the growth is much higher, and we're starting to see the numbers themselves become equivalent, if not greater, than the other age groups. Oh, so this is the last page. What I'm going to do is I'm going to stop sharing for a second so I can sort of switch screens and interact with Tony a little bit and figure out what he thinks the best process is to go through this. And then I can put the screen back up in a space where I can look at it and also your faces. So Tony, what do you have a suggestion for the best process right now to go through the ask, like one by one, or should I read it all and then talk?
Yeah, I think, you make your appeal to us, kind of detail the things that you think we can do. And then we will respond, and I'll have to figure out with Dr. Richardson what we can and can't do. And we have Senator Solomon here, and other legislative officials. So whatever it is, let us know, and then we'll try to figure it out and do what we can. We got about four minutes.
All right. We'll put the screen back up. So I guess the first ask, can you see it? Yeah. Okay, great.
Tony?
The first ask we had is, well, don't take our word for it. There's been an investment in the suitors data set at OHA over the last couple of years. I believe that's getting underway. And I think it would be very prudent to ask OHA to do a full and detailed analysis using the suitors data to help suss out what's happening here in the youth space. What are the circumstances? How are these? How was the fentanyl ingested or smoked or swallowed or injected? Did the user have a prior history of substance use? Were they receiving mental health care? I believe all of those things I just mentioned and more are part of the suitors data set. And I think it would be really valuable to see if OHA could come up with a report out about that, so that whatever decisions are made about what to do about this are informed by data and not just one family's story. Should I keep going, Tony?
Yeah, just keep going. Let us know all of it.
Okay, I'll do that.
Go ahead.
Number two, well, 2 and 3 are broken into short and long term. Number 2, there's a crisis here. Dr. Coltis at OHSU sent a 2-page letter with 60 medical professionals that signed on to the governor in December. Her response was, ADPC and others in the state are already doing all the things that can be done, and you should look to them for how they respond to this. Well, my idea is more clinician alerts like the one that was sent last week in the Portland Tri-County area. That's the best I've seen in the entire country for how you talk to your medical professionals about an opioid naive population and the risks they have from counterfeit medicines with fentanyl. So broadly spread those around. Second, the HIDA director, Chris Gibson, has pointed out that they have something called OD maps, which is a rapid response capability that's only implemented in one county in Oregon, Jackson County, I believe. I believe this is ready to go and can provide near real-time data where there's outbreaks of overdoses and poisonings. So things can be done in real time. Third, I understand a group like Need for Narcan has made a ton of progress. West Lynn, Wilsonville signed on last week, I believe. And I don't know what more is, sorry, Oregon City. I don't know what more is needed here from you, other than supporting them or looking for opportunities to duplicate that effort. And lastly, there are many states and counties that are taking the DEA's One Pill Can Kill campaign and duplicating it locally. King County in the Seattle area has a fantastic Laced and Lethal campaign. And I think statewide billboards, communications through schools in kid language, all this sort of stuff would save lives and be like the easiest thing on the list, frankly. When we look at long-term measures, I had the honor and privilege to be in an amazing prevention symposium that you all put on last week. It was really, really well done. I was filled with hope. I told Tony this last week when he and I met briefly. I was filled with hope for the expertise and the commitment that I heard from the people in the room about what can be done with primary prevention. And I'm asking that ADPC revisit the strategic plan, which was developed before fentanyl really was on the scene, to comprehend the new synthetic and deceptive landscape and the entire population that's at risk, which is now, frankly, everybody. So it's not just the at-risk populations, but everybody. So revisit that plan. Second, when primary prevention approaches are rolled out, hopefully using the settlement money, we ask that they be rolled out to the general population, not just the at-risk population, and that there be mechanisms to refresh and regularly update those primary prevention tools and content, because the synthetic drug landscape is changing way faster than the curriculum cycle. And use data to do it, from suitors and the Oregon Wellness Survey, which, as I understand, is not deeply implemented. So I strongly encourage the use of data to inform how we keep that updated. And lastly, and this, I'm a little really out of my comfort zone here, I think that there are some legislative changes or additions that you all might be an opportunity to influence. I don't know which combination of these rules or statutes might apply, but I think calling out the synthetic and deceptive substance landscape as explicitly as anabolic steroids, for example, which is, as far as I know, is not taking anything like the number of lives that the fake pills are, getting that explicitly in that legislation and make sure that that legislation has a refresh mechanism and a frequency so it gets updated on an ongoing basis. And it's not one and done. That's it. We're just so appreciative of the time to be able to present this. And I know you're running out of time, but we are open to stay longer now or to answer questions online. Our emails are here, and Tony and Heather can help get our contact information to you all.
Yeah, no
John, if you
worries.
could stop sharing, Chair, there are several questions. Kat, Don Mazziotti, if they want to weigh in.
Sure. Can I, this is my first time kind of facilitating a specific ask like this. And so Dr. Richardson, real quick, would it be applicable for us as a commission to say, yes, this is important. We want to look at what we can do with these requests, pass that off to you and your team to see what's feasible, and then revisit it next meeting?
Yes.
Does that sound like a practical way to move forward?
Yes.
So before we get into any detailed discussions about data and stuff, I know there's some data folks in here. Could you just put in the chat like a yes if this is important to you and it's something you want to take action on? You drop that in the chat, and then I'll get to a couple questions. And John, we will look into it. I'm seeing nods and claps and stuff, and Senator Solman's been really moving and grooving. So I think you have an ally there. And then we'll get to a couple questions, and I think Kat, you had your hand raised first, and we have 1 minute left.
Yeah, so first of all, I dropped all the statutes into the chat for people to read. I noticed on your chart there was a very clear distinctive, like, does not include suicides. How are they determining if it's suicidal versus accidental?
As far as I know, that determination is made by the medical examiner.
Okay.
I remove suicides, which the CDC typically does not when they report these. I remove them in order to align the data with the way that OHA reports,
Okay.
which is they take when they're doing their regular sort of opioid reporting and these things, they remove the suicides.
Okay, thank you.
Thanks, Kat. And then who next had their hand up?
Don, did you want to ask your question or make a comment?
Tony?
Yeah.
Don Mazziotti. I wanted to come to understand what the data is showing for folks 24 and older. What's happening in the working population with regard to fentanyl. It would be really interesting to see if it's growing in that population, becoming an endemic rather than a pandemic.
Thanks for that question. You have the deck, and on that page, the age groups are listed. I'm just reading it here, that group, 25 to 34-year-olds, has the highest rate of fentanyl involved death, but a growth rate that's about equivalent to or even lower than the state.
Fascinating.
And also, 58% of those deaths involve fentanyl, which is a little higher than the state average. So less meth, more fentanyl, but a lot less fentanyl and growth than the youngers.
Thanks. And I want to get over to Senator Solman real quick. Go ahead, Senator Solman.
Thank you so much. And I just really want to thank you so much for being here. I watched your video prior to this meeting, and I really appreciate you seeking positive change from the heartbreak that you have experienced. As a mom, I'm there. I wanted to mention that as I'm so very interested. I've been a member of this commission since 2017. I have often been so incredibly inspired by the people that are involved with this commission. And I find that this work and what you have brought forward is exactly why this commission is. And as disappointed as I was to hear of the governor's reaction, I just think that this is what this commission is here for. And I think that we can be a resource. I think that we can be a vessel. And I think that your statistics that you have pulled together is the reason why this needs to be with an exclamation point on it. And I really just wanted to thank you for that. And as you're talking about awareness campaigns, it's really important. I'm a former school board member. Figure out how we involve our Oregon School Boards Association and our superintendents so that they can be part of that message and vessel of awareness and information as well. And I am going to be reaching out to you. Again, thank you so much.
Thank you for those words, Senator. And we have a body of our work that directly touches schools that we'd love to share with you what we've done and what ideas we have.
Okay, go ahead, Commissioner Mike.
Yeah, thank you, Chair. John and Jen, really feel for you all and your loss. I work within the corrections health system in the Multnomah County jails, and so we are seeing a major uptick with regards to fentanyl. And I think we are typically indicative of what we will see in the community. People are very creative about how they go about. I mean, it's in nasal sprays. It's in all sorts of things right now that we're seeing. And so we are, I think, at the front end of the trends as it relates to that. So what I wanted maybe to mention in this space is I would add some information on your presentation on some of the kind of the maybe even pictures of what some of these things look like, just to provide education, especially to the youth and even to the adults, because it is, well, what we've seen is very scary. And I know last week I was talking to Dr. Vines, the health officer, and we saw our first case of one of an unexpected syndrome with fentanyl use that was wooden chest syndrome. I never heard of this before, but basically, effectively, you can't even do CPR because of that syndrome. So it's extremely dangerous. And the last thing I'll mention too here is we've had multiple cases where we're using on average 4 times the average, the amount of Narcan to revive folks when they've come in that are on fentanyl and that didn't know they were using it. So that's another huge educational piece, that using 1 or 2 doses of Narcan is not nearly enough, is what we are finding already. So thank you for your work, and we are here to support you and to be a resource for sure.
Thank you. Thank you for sharing that new information that you've been learning. Just so you know, through Song for Charlie, we have been doing a lot to reach out to kids and parents. Song for Charlie are reaching out to kids on social media and in school. And in fact, on social media, we have reached more than 50 million unique users since August. And if you follow us on social media, you can see that we are showing people what it looks like, showing that it's the M30s and Xanax, and it's in Coke and heroin. I mean, we are trying to get the information that way. So the presentation you saw today was really tailored to this audience. I'm happy to talk to you more and share with you and Senator Solomon, and who else is interested, if you want to learn about what's going on. I suggest following the Song for Charlie newsletter, and then we can also, share our school efforts and media efforts as well.
Okay, well, thanks guys for coming, and looks like John, you're probably dropping some stuff. Yeah, that's what I thought. Chat, appreciate it, and I'm gonna move any additional comments to the chat so that we can move on with our agenda, and we appreciate Gregory Ahrens with it's Craig Moshak, I believe, an economist with OHA. Thanks for giving us a little wiggle room there, and you can go ahead and give us an overview of the behavioral health workforce study. And John and Jen, you're free to stay on and contact me and Dr. Richardson, and we'll look at your recommendations and see what we can do and how we can help.
We'll just go on mute, Tony, and just read the chats for a minute, and then we'll say goodbye. And thank you again.
Yeah, sounds great. Thanks so much for coming. Go ahead, Craig.
Great, thanks. Can you guys see the presentation there?
Yes, sir.
Great. So yeah, I'm Craig Mosbeck. I work for the Oregon Health Authority in the health Health Policy and Analytics Division. And we just finished up a study, the Behavioral Health Wage Study, and I'm here to happy to present that to you today. The final report was submitted to the legislature in February. So where are we today in the workforce? So there's a large gap between the need for services and the capacity of the behavioral health system to deliver those services. And you've heard a bit about, historically, Oregon has had high needs for both substance use disorder and mental health services. And there's high rates of illicit drug use for both adults and youth. So more is needed. There's more need coming from the pandemic, again, as we heard, with the increased use of alcohol and other drugs. And the behavioral health workforce was impacted by the pandemic as well, including people choosing to leave the field. So there's a crisis in Oregon's behavioral health system with not enough practitioners and high workforce turnover, and this has real implications for populations needing access to treatment and services. So it's important that we have providers who are members of and understand the strengths and challenges faced by the communities that they're serving. And we know that currently people of color are underrepresented among all types of behavioral health providers. People also need providers who can relate to their lived experience, and thus with this study, there was a focus on peer support providers. And we know that the populations harmed by health inequities have long struggled to obtain access to both culturally responsive and linguistically appropriate care. And this includes communities of color, LGBTQ+ community, linguistically diverse populations, and the intersections among these with rural communities. But we're seeing some forward momentum here in the behavioral health system. We have historic investments to improve the access to services. There's funding coming from Measure 110. And then the 2021 and 22 legislative sessions, there was a lot of work on behavioral health. For example, with the workforce, House Bill 2949 last year included $80 million to develop an expanded, more diverse workforce. We have a new initiative to create a statewide behavioral health metrics and incentive system. And we've seen increased awareness around substance use and mental health issues, especially during the pandemic. And this may be helping to decrease stigma, which would be helpful. So our collective goal is to move fast forward. We have to work harder to authentically engage communities and value their lived experience. But with this momentum, this is a good time to be working on transforming the behavioral health system and increasing access to services. So this behavioral health wage study comes from House Bill 2086 in 2021, and it required a study with recommendations for how to increase wages for the behavioral health workforce. The Oregon Health Authority contracted with the Center for Health System Effectiveness at OHSU. They had a great team working on this. I also wanted to acknowledge we got important assistance from other staff at the Oregon Health Authority, including Brandy Hemsley and Daniel Garcia, and then ADPC staff, Jill Gray and Dr. Richardson. So here's a quick outline of the presentation. We know that wages are low for behavioral health providers, those serving people with mental health needs, substance use disorder, gambling addiction. The main cause of this is that there is low reimbursement rates. There's not a lot of money in the system. This causes a workforce shortage because people choose not to get into the field, and they may leave the field because they're not able to, support their family, et cetera. This leads to high caseloads because of the shortage of the workforce. And then that again leads to more provider burnout, which could have people leaving the field again. But there's also administrative burdens and the lack of advancement opportunities, which is hindering people staying in the field. And then all this causes harm to people who are needing services that are not able to access providers and get access to services. So this report is centered on equity with a focus on communities of color. And we gathered input from those with lived experience, both behavioral health service users and providers in, again, substance use disorder and mental health. We did 2 focus groups of behavioral health service users, and 1 was conducted in Spanish. We did 3 focus groups of behavioral health practitioners. 1 was consisted of providers of color. And then we had meetings with about 7 organizations treated them sort of like focus groups, like the Latino Emotional Health Collaborative and the Oregon Consumer Advisory Council. And we did about 25 key informant interviews. So one of the main things we heard is that people needing behavioral health services have difficulties finding available providers. Wait times can be very long, and this is worse for those who need bilingual or bicultural specific or culturally specific services. And a person needing help with substance use disorder may have a window of opportunity where they are choosing treatment, and they need to get access to that treatment when that window is there. And also with workforce turnover, people express frustration with reestablishing a rapport with a new provider or reliving their traumas. And this provider turnover adds other burdens around care coordination, insurance billing, and then, of course, challenges with finding a new provider. So we know there are under-resourced components of the behavioral health system, and this makes it more difficult for people to transition between levels of care. And we know that people are very vulnerable in the immediate time around the transition, for example, coming out of incarceration or residential treatment. And sometimes there's not enough resources in the new care setting. That is, there's no availability for the person to transition into the most appropriate care setting. So for example, someone might not be able to be discharged from a residential setting because there's not enough availability of community-based services. And then people who need that residential treatment can't be admitted because there's not space available. And we know that practitioners are also leaving the community behavioral health field for primary care, school settings, and hospital employment because there's better work environments and higher wages. So providers said to us that improving workforce recruitment and retention is not possible without increasing wages. For example, the average peer support specialist makes $18 an hour. And this kind of surprised me. The average social worker in the substance abuse mental health field makes 40% less than the average social worker in healthcare. And expanded benefits can also help in addition to wages, such as health insurance, housing stipends, childcare, paid time off. And another problem is the large differences and wages between the licensed workforce and those without licensure. For example, workers leave their current employer when they obtain licensure because they can earn a higher wage in a different setting. And this creates scenarios where providers, sometimes with the least amount of training, care for people with the greatest needs. And you can see that with the crisis now in residential care, residential treatment. So I'm retelling this story with permission from Caroline Zarzak. Caroline enjoys her work as a peer support specialist, and she also enjoys traveling and taking pictures, you can see here. And she brings to her profession the experience of a trauma-induced eating disorder and alcohol use disorder. Working through these challenges and then being able to process her trauma, Caroline chose to become a peer support specialist in both addictions and mental health. She works for the Deschutes County Behavioral Health, where she uses the knowledge gained from her lived experience to work with and advocate for people using behavioral health services. She said, part of what peers do is advocate. It's appropriate and crucial that we advocate as strongly and passionately for ourselves as we do for the consumers we partner with. And during recent contract negotiations, Caroline worked with her union to advocate for all peers, and she highlighted job descriptions of what peers do that were part of other positions that were paid significantly more. So now the new contract in Deschutes County includes wage increases of over 20% for peer support specialists. And I asked her lessons learned, and she said, be relentless and respectful, be aware of misconceptions about peers that need clarification, and appreciate your allies. You probably have more than you realize. Looking at reimbursement and reimbursement rates, we heard about low reimbursement rates that are not always commensurate with the behavioral health practitioner's lived experience, education, and skills that they bring to their profession. And without increases in reimbursement rates, it's going to be difficult to create significant sustained increases in wages. Also, most insurance companies' plans don't allow direct billing by the mostly lower wage workforce that doesn't have licensure, like peer support providers. So expanding the types of practitioners and services that can be reimbursed can lead to increased wages. And we know there's challenges with service users that have co-occurring needs, substance use and mental health challenges. These services are usually provided in different settings by different providers with different billing codes. And these differences create barriers to effective coordinated care. There also appears to be disparities in reimbursement for substance use treatment compared to mental health treatment. So reimbursement for the most common service of 60 minutes of substance use treatment is about 1/3 of the reimbursement of 60 minutes of psychotherapy for mental health care. And we know that provider burnout and turnover is also fueled by the work environment. So providers are sometimes expected to carry large caseloads with high administrative burdens and support people who often have very intensive needs. So that we heard that the providers are struggling with the administrative burdens and the paperwork. And thus we need to continue efforts to reduce these administrative burdens, such as some that were initiated during the COVID-19 pandemic. And their job satisfaction is also impacted by the burdens of inflexible schedules, being on call for crisis services, and sometimes insufficient supervisory support. And lastly, provider recruitment and retention would be helped by creating clearer pathways for salary increases and career advancement in the behavioral health field. So we need to improve workforce development here. And House Bill, as I said, House Bill 2949 includes $80 million to recruit and retain providers who are people of color, tribal members, and residents of rural areas of the state. This bill can fund career pipeline programs, tuition reimbursement, loan repayment, and training opportunities focused on culturally specific care. There's also a need for diversity in agency leadership, and this could help support the recruitment and retention of a diverse workforce more broadly. And also wage or rate premiums could support bilingual or biculturally specific positions. For example, Multnomah County now uses their system of knowledge, skills, and abilities in job descriptions, and this allows for increased pay for employees who can provide, for example, bilingual services. We need a robust recruitment strategy that includes outreach to K-12 schools, community colleges, and universities. And it's essential that wages in the behavioral health field increase and working conditions improve, because otherwise people of color, tribal members, residents of rural areas are going to be recruited into a behavioral health workforce that's underpaid and subject to burnout. So we're boxed in by the limitations of the study. First, there's a lack of good data on the lower wage professions. We have much better data on the licensed professionals. And the focus of the study was the systems definition of behavioral health worker. So for example, we know that in some community-based agencies, there are staff who provide behavioral health services, but they don't have a behavioral health job classification. There's also was a sort of a lack of focus on primary prevention here because the system itself focuses much more on treatment and recovery. And many people seek help for behavioral health issues in ways outside of the behavioral health system. And the Coalitions of Communities of Color did a good study on this where they interviewed people needing behavioral health services. And that was investing in culturally and linguistically responsive behavioral health care in Oregon. And they found that many people looked to the faith community and other places for their behavioral health needs. Also, the wage data that we have access to are not available by race and ethnicity. And then this is a problem for the study, but I think it's a problem for the behavioral health field generally, and that's the complexity of workforce categorization. So there are more than 20 different types of behavioral health practitioners in Oregon. These categorizations don't always map to the national data we get on wages, et cetera. And it also makes it very difficult for someone who wants to get into the field to know where they can go and again, what their advancement opportunities are. And also complex is the reimbursement structure. So comparison of the reimbursement is really difficult. So now I'm going to talk quickly about the importance of behavioral health in terms of what society thinks and the stigma around addictions and mental health. And these data come from a public opinion survey in Oregon of adults in November of last year. here you can see on the left that when asked, what's more important to you, physical health or mental health, the vast majority of people say that they're equally important, almost 80%. But now on the right, you can see when people are asked, how does society treat mental health versus physical health? You see that people think society treats physical health as more important than mental health. So the public opinion survey showed that 87% of Oregon adults agree that stigma is a barrier keeping people from seeking help. And so a couple comments from survey respondents were like, the stigmatizing is easing, but there's still a lot of ground to cover. It definitely needs to become less stigmatized, and I think it's getting there, but the stigma is still a major barrier. So I've been thinking about, whether we could measure changes in stigma over time. And this is a question. I've looked at a number of questions and came up with this. And we could talk about this at the end if you want, about whether this is a good way to measure stigma or whether there might be a better set of questions. But I will say that we need to ask it separately for substance use disorder, or as I have written here, drug abuse problem, versus mental illness, because I think the stigma is different between those two. So again, here's the summary. As I said, I think maybe stigma around substance use disorder and mental health should actually be at the top here, with the arrow going down to affecting all of these things below. But we know that reimbursement rates are low for behavioral health services. This causes wages to be low, and then all these things that lead to a workforce shortage. And I'll just note, recently this became a national story. There was an NPR, National Public Radio headline that Oregon has funding for addiction recovery programs, but not enough employees. And this is a story about the implementation of Measure 110, where they say now the problem is finding the workforce to staff this effort. So a quick summary of some of the recommendations that came out of this report were, again, increasing reimbursement rates so that wages can be increased. And I will say that there's two important bills coming out of just this legislative session that ended earlier this month. One is House Bill 4004. This includes $132 million to increase wages, benefits, and bonuses for the behavioral health workforce. And then there's $42 million for increasing reimbursement rates. And the estimate is this will be able to increase rates by an average of 30%. We also need to expand services that can be reimbursed and the provider types that can directly bill. And also changing wage structures to fairly compensate the practitioners who can provide bicultural or bilingual care. Further reducing administrative burdens and claim delays and denials. And we definitely need a robust workforce recruitment and also training pathways and professional development for the workforce that we currently have. So that's the end of the presentation. I'm happy to answer questions and hope we can have some discussions of the implication of this study.
Sure. Thank you so much, Craig. Do we have any? Okay, we got Vanessa. Raise your hand right there. Go ahead, Vanessa.
Thank you so much for your presentation. That was extremely educational and very helpful. I'm curious, can you give me some examples of the types of services that are not currently reimbursable?
Care coordination would be one. Also, we heard, there's really it's huge importance of having bilingual providers when someone's primary language isn't English. And we found that when you don't have bilingual providers, any kind of, you can only get reimbursed for a healthcare interpreter if you're doing a billable service. So all the coordination of getting appointment times and stuff like that, you don't get compensated for that interpretation or bilingual communication. And the coordinated care organizations in Medicaid are doing the best job with using peer support specialists, but often that services like that are they can't directly reimburse, they can't directly bill for those services.
Okay, any follow-up, Vanessa?
No, I see Jill Archer in the chat added that services before a formal assessment / diagnosis and treatment plan are not technically reimbursable. So no, I just want to know where are the gaps and how can we advocate for closing those gaps? That's what I want to focus in on, because I definitely see that need in one of the other roles or hats that I wear. My community has a huge need for mental health services at every price point. And I have heard from mental health service providers about these burnout numbers, these recruitment challenges. So I'm certainly seeing that impact in my community in Salem. So thank you.
Mhm.
Okay, can I ask you a question, Craig?
Yeah.
I've been kind of analyzing the workforce a lot and thinking about it. And I'm concerned about the volume of funds that's getting injected into the marketplace really quickly for two different reasons. One is, a lot of these different service types, they work together, right? You got to go to detox before you go to outpatient, like there needs to be kind of this linear service experience that happens in a lot of ways. And I'm just wondering, have you done an analysis on how this injection of funds may, decrease capacity in certain parts of the system or the marketplace versus increase over here? Like, has that been a part of your analysis at all? Because I'm concerned it won't grow kind of in the places it might need to, like residential and detox.
That wasn't part of the work that we did with the study. I will say that the $132 million that's going towards wages is focused on provider agencies that serve at least 50% Medicaid, Medicare, and uncompensated care. And then the $42 million increase in reimbursement rates, that won't be an across-the-board rate increase. They'll be, thinking about where that is needed most. I don't know the details, but I know there's been like a 10% bump in some residential treatment rates during the pandemic. I don't remember what that was focused on, but I know that was specifically in residential care because there is a real acute crisis with a lack of workforce there. And as I said, what happens is often people work in residential treatment and then they go get their licensure and then they move to a place that they can make more money, and it's an easier work environment.
Okay, thanks for that. And then, the second part of my question is, did you guys do any projections on what you think would be a reasonable wage adjustment for behavioral health workers to have more parity with physical health?
Yeah, that kind of analysis is pretty sophisticated and would take a lot of resources. We focused on other parts. There's just these sort of anecdotal things. I mean, you can think of a peer support provider. The average wage is $18 an hour, and now that's below the wage of fast food restaurants in some places. And that one stat about a social worker working in substance abuse or mental health is making 40% less than the average social worker who's working in healthcare, like at a hospital, in a medical system. So there's no good solid data on like what that right number is. Pretty clear consensus that everyone agrees that the wages are low for behavioral health providers, and that's causing people to leave the field.
Okay, thanks, Greg. And I don't want to eat up all the time. Is there any other questions from any other commissioners? Okay, well, thank you so much, Craig. And I may follow up with you offline if that's okay.
Absolutely, thanks.
Okay, thank you so much. Next up, we have Erica Crable and Gregory Ahrens.
Thanks, Tony. I'm going to share my slides on my end. Let's see. Can you all see our slides Awesome. Thanks so much. And thanks so much for having us. We really appreciate the work that you all do. We've been coming to your meetings for the last year and following all of your initiatives. Greg, are you there? When I share my screen, I can't see as well the rest of the room.
Thanks everybody for having us. Eric and I are both at the University of California, San Diego, Department of Psychiatry, and our Dissemination Implementation Research Center, and but doing work here in Oregon. In fact, I'm up here in Clackamas County right now and spent part of the year up here in Oregon, which is near and dear to me. So let's go to the next slide. So we're going to talk about a research project funded by the National Institute on Drug Abuse that we're actually in the process of doing here in Oregon, and it touches on some of the issues that we've heard around workforce. And the main issues are really we're thinking about the quality of psychosocial care and addiction treatment, and also trying to address the fact that many times agencies and research projects try to implement evidence-based practices, they go away very quickly. So we're thinking about how to maintain quality of psychosocial care and behavioral care in the existing workforce and existing agencies. And this is something that we talked with our program officers at NIDA about. They're really interested in thinking about how we sort of provide supports and help counselors and clinicians develop their expertise, help supervisors support those clinicians and counselors as they become more effective in working with those with substance use disorders and mental health problems. So the project aims really focus on our approach towards thinking about developing clinic leaders, their leadership skills in supporting use of evidence-based care, but also working with the organizations, executives to support those leaders in the process. But we also understand and realize that this is within a complex system, that oftentimes when evidence-based practices, evidence-based care is implemented, that we really don't consider, the larger landscape. What's the policy landscape? What's the funding landscape to support that? So we're thinking about the practicality of implementation and how it fits into the larger system. So we have what we call our leadership and organizational change for implementation strategy. And we want to test whether we can improve leadership skills, leadership behaviors. And this is from the staff perspective. Is my leader more effective in really supporting me and my work and supporting the use of evidence-based care, and improve that climate as well as the reach and effectiveness of evidence-based practices that are implemented. And the other piece, as I alluded to, was thinking about how we can improve alignment between service systems like OHA and the Alcohol Drug Policy Commission, but also provider organizations, providers, and managed care organizations like the CCOs. I know that was a lot in a short period. Next slide, please. So let me just briefly describe what LOSI is, and the SL stands for system level. It develops that clinic leadership and aligns systems and organizations with the goal of successful implementation, sustainment of quality of care. It's data-driven. It uses 360-degree assessments to understand sort of leaders' skills, abilities, and behaviors. Those data are used in working with leaders to co-create leader development plans to help them develop their leadership skills, both general leadership and specifically focused on implementation. We do the leadership training, leadership coaching, very brief, just to keep leaders on track. But we also work with the organizations around how they can use organizational strategies to support those leaders. And we foster communication between executives in agencies with their in the trenches leadership staff, their clinic leaders and their clinical supervisors. And then we're also working with and in discussions with OHA and meeting with you all and learning more about the initiatives of the Alcohol Drug Policy Commission, and think about how we can best promote and support the use of evidence-based care. Next slide, please.
So one of the reasons that we wanted to come and meet with the Alcohol and Drug Policy Commission, and why we've been following you and your work over the last year, is because we see a lot of alignment between the LOS-ISL components that Greg just described and several goals outlined in the Alcohol and Drug Policy Commission strategic plan. So we want to help providers across the state respond to your policy directives. So as Greg mentioned, LOS-ISL, it's a leadership intervention, and that 360-degree assessment he mentioned, we're doing that right now across the state with provider organizations, helping to measure their provider implementation climates, including how they work with their CCOs, how they work with OHA and other systems level agencies. And we're using those data to help develop the leadership training and coaching that they're receiving right now from us. And that coaching is really focused on promoting communication, those leadership skills, and collaboration across agencies and provider organizations. And we've been reaching out to our systems partners like OHA, like the CCOs that the provider organizations administer benefits for. And we want to engage with the Alcohol and Drug Policy Commission to really think critically about what are the best ways to develop collaborative strategies that support your strategic plan and really get at supporting evidence-based practice, substance use treatment uptake, and sustainment over time throughout Oregon. I'll turn it back to Greg.
Okay, so when we talk about the evidence-based practices, or the thing that we're going to implement, we've done a lot of work with different evidence-based treatments in child welfare, in mental health, in addiction. We're focusing on motivational interviewing for this particular project, but I'm also going to talk about what we call, it's a quality support platform called Listen, L-Y-S-S-N, that uses artificial intelligence and computational linguistics to give feedback about fidelity, quality, session content, and to really provide that feedback that clinicians and supervisors can benefit from in improving workforce skills around successful use of evidence-based practices. So I mentioned both MI and cognitive behavioral therapy because the Listen platform has that capability to address both of those. So, you know, we focus on those because they're both useful throughout the substance use disorder care continuum, and they support treatment initiation, engagement, better outcomes in substance use disorder treatment, but also, again, help our workforce develop skills in providing care. So I want to talk briefly about the Listen platform. And the first thing to say is this is a HIPAA compliant, encrypted cloud-based platform that was developed through over a decade of research at the University of Washington. And what it does is sessions are recorded. The data, none of the data exists on the computer. It's encrypted, goes into the cloud. It's instantly transcribed, and it generates analytics. And those analytics can be used to help clinicians understand how they're interacting with their clients. It provides feedback on things for MI like empathy, open questions, reflections, and it shows clinicians how they do with those different issues. And they can in fact look at anywhere in a session to see and think about their interactions with their clients and what went well, what went maybe not as well, and think about how they can build their skills. And so those Listen feedback and analytics, they support training, supervision, quality assurance, and improvement. Other things on the horizon that Listen is probably going to release later this year is the ability to provide a template for case notes, so that at the end of a session, a clinician can pull that template and edit it for that particular session. So it really can help reduce some workforce burden in terms of case notes and compliance with documentation. The other things that they're working on is, identifying in the conversation of a session if there are issues around, for example, suicidality, particular drug use, whether problems are work, home, school-based, those types of things. So those are all things on the horizon for Listen. Next slide, please. And the analytics, and this is what we're thinking about in terms of quality. We can use Listen data to think about quality of a clinic, of a clinician, of clinicians who work under a given supervisor, quality of individual sessions with individual clients. So there are different metrics that allow the ability to visualize population level quality all the way down to individual session quality. So we're thinking of this as also a tool that could be used to understand broadly, how is an agency doing? How is a clinic doing in terms of their quality of care? And thinking about whether metrics like this could be useful for folks to really understand that quality of care across the continuum. Next slide, please.
Okay. So we recognize that the Alcohol and Drug Policy Commission is a really important player in the Oregon substance use treatment systems environment. Your commissioners represent significant expertise from treatment providers to individuals in recovery to law enforcement and other judicial experts. And you know the issues your system is facing. You talk about them on these meetings, and you're also fortunate to be in a position to identify and implement solutions. So we've been coming to your meetings for the last year or so to learn more about your commission, what you do, and your service environment. And we're hoping that a partnership with your commission will help inform our understanding of the substance use treatment environment in Oregon, help with the co-creation of strategies that support evidence-based practice treatment for substance use disorders across the state. And we'd also really like to help support the commission's strategic objectives. So I know we're short on time. I'm just going to run briefly through 3 asks of your commission, and then we'll stop presenting and get your feedback. So first, we will be planning to reach out to a handful of commissioners to conduct one-on-one confidential qualitative interviews. And the purpose of this is to help us learn about the service environment in Oregon, what the commission is prioritizing, and any sort of barriers that have been in the way to achieving your strategic plan. And we'd like to do this soon, and then again at the end of the study in about 5 years-ish. And we've spoken with Dr. Richardson about this, and he has said if you do this, we'd really like to see a report about the findings. So we're happy to share a high-level report of de-identified findings to help with the commission further their own work in this area. The second ask is that we'll be reaching out annually to ask commissioners to complete a brief survey on implementation climate for the use of evidence-based practices and Listen. And this will really help us identify opportunities to support evidence-based practice use and understand leadership and challenges at the systems level that you all are facing. The third ask is that we would like to give you an update on our study findings and progress annually. So this would include things that we learn across provider organizations that are currently using Listen to implement MI with fidelity, and what we learn from engaging with the CCOs and OHA throughout this process. And we think that this could also really create an opportunity to integrate your feedback, co-develop strategies that advance your strategic plan, and improve alignment across the state agency and all of your other commission partners. So I can leave it there for us. I know we're short on time today. I'll stop sharing the screen, but please let me know if you want me to put any of the slides back up.
Yeah, thank you so much, Gregory. And Erica. Dr. Richardson, did you want to add anything to this presentation? Sound like you may have some communication with them prior.
Yeah, we've been meeting for about a year off and on. They have presented a couple of different times in our commission meeting. We've entered into a interagency agreement with the university around this study. I think it, provides some opportunity for us as we're trying to implement our strategic plan, that there's some expertise that they bring to the table. You all bring to the table a bunch of expertise that I think can inform their work in this project. And I thought it was a good connection between their project and the work that we want to do. I think we support them, they support us, and I think it ultimately Oregon will be better because of it. And they'll be reaching out to you, as they said, to participate in survey and interviews. And I would encourage you all to participate so that we can improve not only the practice around the state, but also look at whether or not there are practices that we can improve as a commission within our own work. So that was sort of a hidden agenda that I had in agreeing to participate in this process, is to see how we could also do our work better. So thanks, Chair.
Yeah, I suspected that much.
Tony?
Give me 1 second, Don.
Sure.
So, thanks, Reggie. I suspected as much. It looks like there is some activity in the chat already. I think Nate said he'd be happy to volunteer. I assume that most would. If you want to drop anything in the chat, like maybe a better way to contact or a way to reach you, if you want to volunteer, that might be really helpful. I know Dr. Richardson will send out communications later. Go ahead. Who was that? Who was talking? Sorry, I kind of broke up there. Was it Don?
It's Don Mazziotti. Yeah.
Sure, go ahead, Don.
I just want us to, I think that the suggestions, first of all, I think it's a fantastic opportunity. And I think it's brilliant on the director's part to create the partnership with these people. They obviously know what they're doing. And I just want to compliment the process and be happy to participate in any way, because several of the issues are obviously raised at a commission level that really requires discussion, which I would assume, Tony, you would orchestrate.
If that is my duty, I will do it. Yes, the best I can. Thanks for, allocating that responsibility to me. Then I got Tony Bigland's hand up. Go ahead, Tony.
Two questions. Following up on what Don said, is there a plan for or taking action on the asks that Erica just listed? And then the second question is to them. Is there a model policy, a state level model policy that would be relevant, or set of policies that would be relevant to building a more effective treatment system?
Well, I think I'll give the policy question to Erica.
Yeah, I'm sorry. I was putting some information in the chat. Would you mind restating the policy question for me?
I'm wondering what state level policies might be considered that the commission could recommend to the legislature that would create a kind of system that would support the kinds of developments that you're working on.
Yeah, I think that's a great question. And that's exactly the kind of thing that we'd like to learn throughout the course of this project, by working and soliciting feedback from the providers who are using Listen to enhance their delivery of motivational interviewing and cognitive behavioral therapy. And we'd also like to sort of solicit ideas in our brainstorming sessions with you all, because things could look like, changing reimbursement policies. Obviously, that's a huge thing to work toward. I don't want to be naive about what is achievable in a steady timeline. But, if we don't put things in motion, they never come to fruition. So maybe something that we can work toward is thinking about how we bring OHA, CCOs, and other folks to the table to talk about reimbursing providers for their time, learning evidence-based practices, using something like Listen or Listen itself. Just anything. We're open to creative solutions and proposing new ideas. Oregon is a unique environment. I used to work with a lot of state Medicaid programs and have spent a lot of time supporting substance use treatment policy implementation across the country. Oregon has always been doing the most. You all have a behavioral health plan from the governor's workforce. You have your strategic plan. I think we can look at the suggestions and priorities in those documents and put those forth as ideas too.
Yeah, I think just piggybacking, one of the things we're thinking about with Listen, we struggle with thinking about how do we really understand the quality of behavioral health care and especially psychosocial services. And it's a bit of a black box. It's very expensive to, for example, record, or it has been historically, record sessions, have them coded for fidelity, and get feedback. And that really doesn't fit with what we know about how adults learn. It's important to have feedback that's quick, that's targeted, that can help providers develop their skills. And we think that Listen has great promise in achieving that. So the degree to which something like the Listen platform could be used to understand quality and maybe even incentivize quality care could be one approach to how that gets used. The other thing we've looked at is a number of different platforms for different evidence-based practices, and there's some out there that are very expensive. So, for example, web and app-based approaches to contingency management can cost over $300 per client per month. And we know that Medicaid reimbursement rates for contingency management are far below that. But the Listen platform is relatively affordable in terms of, I think the rate right now is under $30 a month per clinician, regardless of the number of cases, for example. So we're looking for solutions that not only could be effective, but could also be practical in terms of funding.
Okay, thank you. Nate, seen your hand raised. You want to hop in?
Yeah, thanks, Mr. Chair. Thanks, Gregory and Erica, for your presentation. I really appreciate it. So I work for Community Corrections. I've been here for a couple of decades now. And in 2003, I think that was the legislative session that passed Senate Bill 267. That basically told us to do evidence-based practices, and it empowered us to have outside external audits, right? Those were very, very valuable. So I commend you on just presenting to the ADPC on this initiative, this philosophy, that making sure that we are holding our treatment resources accountable to fidelity and making an impact on Oregonians. So thank you. And I really appreciate your presentation, and I'd be happy to volunteer to be interviewed.
Great, thank you so much. And this always comes to that balance of we really envision this as something that supports the workforce and supports quality, and don't intend for anything to be pejorative in any way. And so that's our philosophy, and really appreciate your comments, Nate.
Yeah, Tony, quick question. I see that you have SUD treatment specifically called out as your focal point. Would this also include any harm reduction or peer-based recovery support services? I teach motivational interviewing to peers and stuff. It's real basic. It's not clinical level, but it's real basic. And would there be any evaluation and a potential to increase the competency, especially in the recovery service world? There's a lot of professional development that needs to happen as the workforce marketplace expands in that area.
Yeah, I think the target or the specific, a clinical question or prevention question can be addressed. It's all about helping to develop those skills. And it could be, developing skills of peer support workers or licensed clinicians or, certified counselors. So we're firm believers in, talent lies in a lot of places. And so we want these tools to be as accessible and useful as possible.
Okay. Any other quick questions here before I move us on? Okay, happy to hear from you guys here in the near future. And let me know if I can help nudge the commissioners to participate. Tony Biglin and Tori, really quickly, I got Kimberly on. The agenda got shifted around a little bit. Are you guys cool to wait to give the symposium update until after Kimberly's done?
That's fine.
Is that cool with you, Tony? Well, I will I think we lost Tony for a minute. Hopefully he comes back. So Kimberly, you're up. And I'm gonna cut you short probably a little bit, 20 minutes.
That's just fine. No worries. I'll try to be quick, and thank you for accommodating my schedule. We had a task force meeting for our the Attorney General's Consumer Privacy Task Force, and I'm the chair of that task force, so I had to jump from one place to the next. So hello everyone. My name is Kimberly McCullough. I'm the legislative director for the Oregon Department of Justice. I appreciate the opportunity to come here and speak with you about the National Opioid Settlement Funds that are coming to Oregon, the process for putting those funds to good work, and the legislation that we got passed this last legislative session that will help enable all of that from happening. So I'm going to give you a brief overview of the litigation that we've been involved in, then the requirements and under the national settlements for that litigation, an agreement that we came to between the state and the cities and the counties about how to spend those settlement funds, the enabling legislation, which was House Bill 4098, and then our next steps. And so I'm going to fly through this pretty quickly, but feel free if anyone has questions as I'm going to jump in, and I'll also be happy to answer questions at the end. So for about 15 years, or actually longer, Oregon's DOJ, our legal team, has been a leader in major multi-state litigation and settlements that involve the pharmaceutical industry, including a number of cases against opioid manufacturers, distributors, and then also firms that assisted the manufacturers and distributors in promoting opioids. We have some really great information about that on our website. And so I'm just going to drop a link in the chat right now so that if you want to take a look and see more information about that at a later date, you can. It has, and that continues to be updated as things happen. So there are some recent settlements that we have reached. In February of last year of 2021, we settled with McKinsey & Company. They're one of the world's largest consulting firms, and they assisted opioid manufacturers and distributors in promoting opioids. That resulted in a settlement. The global settlement was about $573 million, and $8 million of that came to Oregon. Those funds were deposited in the Measure 110 account. It was actually the first funding that got into that account, and it was deposited there essentially to help get that group up and running, because there wasn't actually any money allocated and there was work that needed to be done. That is the last of the funding that will go into that Measure 110 account. Any future opioid settlement funds are going to be deposited into a prevention, treatment, and recovery fund that is a separate account. And that's what I'm here to talk to you about today. So just last month, one of those settlements that's going to be producing money for this fund, we reached settlement with the 3 largest national distributors of opioid drugs and with the drug manufacturer Johnson & Johnson. Oregon will ultimately receive around $329 million from this settlement. It is staged out. We will receive that over about 18 years. And of that $329 million, 45% of the funds will be deposited into a prevention, treatment, and recovery fund that I already mentioned, and I'll describe more about that in a moment. Earlier this month, We also announced an additional settlement with Purdue Pharmaceuticals and the Sackler family. If you're not familiar with them, the Sackler family is the family that runs Purdue. That global settlement is going to deliver about $6 billion nationally for their role in the opioid epidemic, which I will say is extremely appropriate, but never could be enough to roll back all of the harm that were caused. I just got a question about the other 55% of the funds. So I mentioned that 45% of those, the Johnson & Johnson distributor fund is going into the account. The other 55% is going directly to Oregon cities and counties for them to spend on prevention, treatment, and recovery at the local level. That's part of the agreement that we have with the cities and the counties, and I'll provide a little more detail about that in a moment. And thank you for asking questions, and feel free to pepper me with more if you have them. So the Purdue Pharmaceuticals and Sackler family litigation is going to result in $97 million coming to Oregon. That will be divided up again between the cities and the counties and the state. The calculations for how much of that $97 million goes into the fund is a little complicated. It's 45% of $56 million. That $56 million is part of the Purdue bankruptcy, but it also includes the money going to the fund will also include an additional $34 million that just the state of Oregon reached with the Sackler family. And then it's possible that there'll be another $7 million coming depending on the sale of some assets by the Sackler family. So that probably totals, if I'm just doing the quick math in my head, it's more than $50 million that will be going into the fund from the Purdue case. There are more potential settlement funds coming down the road. We are actively engaged in litigation with a company called Endo International, and there are more things in the works that I can't talk about. And so just know that we have a team that is diligently working, and we'll do everything that we can to hold everyone that is responsible accountable and to get more funding for Oregon. So under the national settlement agreements, this is for the distributors and the J&J and the Purdue and Sackler settlements. So all of that funding that's coming in and going into the Prevention, Treatment, and Recovery Fund, those funds have to be spent on prevention, treatment, and recovery. If folks are familiar with what happened with the tobacco settlements, master settlements from years ago, there was a lot of desire, I think, among many people that money should go to alleviate the harm that was caused by tobacco. But unfortunately, that money has been spent for a variety of things, right? And so what's written into these national settlements is very specific restrictions on the funds. I am going to go ahead and put another link in the chat for you all. This is the list of all of the potential uses that that the funds can be used on. And I will just say this list is very broad. It was created to apply to every single state in the nation, and different states have different ideas about what they want to spend the funding on. And so Oregon is not going to spend the money on every single one of these things, but at least it is limited, right? That it can't be spent on roads, for example, or some other random thing. It really has to fit into these categories. I see, Senator Solomon, that you asked a question about accountability for the cities and the counties. There's accountability for the cities, the counties, and the state. So there is a settlement administrator at the national level, and they will be tracking where all the money is going, and there's reporting requirements that have to go back to that settlement administrator. And if there are misuses of funds, there is civil liability for that. There are consent decrees that we are in the process of filing here in Oregon, where an Oregon judge can actually enforce that restriction requirement. We also, and I'll get to this in just a second, but we when we negotiated our agreement with the cities and the counties, we are also requiring them to report to the state so that we can also see how are they spending those funds, and it has to happen every single year. And like I said, this is going to last for 18 years. So there will be a lot of opportunity to sort of see what's going on and make sure that it's happening right. Yeah, super important. There is a limitation on the use of funds that only 5% can be used for administrative costs, and that is across the board. Under the national settlements, there was generally a framework that the national settlements provided, which said, hey, state, you have to divide the money up. Some has to go into a state fund. Some has to go directly to the cities and the counties. They also have a complicated percentage that they developed for every single city and county that's like, okay, based on their population, based on the number of opioid deaths, based on a variety of other factors, they came up with these percentages for how it gets distributed out across the state. For the money that goes into a fund, the national settlement said, okay, we want you to have a board that oversees that fund and then decides how that fund is going to be spent. What the national agreement allowed us to do was to have some play in, who sits on that board, how does that board operate, some negotiation about the percentages of how much goes to the cities and the counties, how much goes to the state. And that led to a very long negotiation between the cities and the counties and the state. And then in December of last year, we reached an agreement between the state and the cities and the counties about the process for distributing the settlement funds. And I'm going to share another link with you all. It is a public agreement, and so you can go ahead and take a look at that and see what the agreement is between the cities and the counties. I'm just realizing I got a question. Does it require the funds supplement existing state and county funding on prevention as opposed to replacing funding? Oh gosh, this is something that gives me a little bit of heartache. And I think, we had a number of conversations with some of you here, Heather and Tony. I know I talked to you about this as we were going. We wanted very strongly for there to be requirements that there be sort of a non-supplanting language, both for the state funds and for the local funds. We were unable to get that type of language into the agreement. It turns out that is way more complicated than I had ever imagined. For the state, it actually would violate our state constitution to put something like that in for the state requirement. I know, yeah. And for the cities and the counties, it was sort of like, well, if the state doesn't, if there's not, we can't impose. And then also that's just complicated. So, here's the deal about that. I think that we need, as we move forward, to have a lot of attention paid to how these funds are spent, and we need public accountability, right? And so that's part of where we have reporting requirements, and we have people looking at it. There's going to be a board. There's going to be a lot of interaction with the ADPC and with you all taking a look at this. And so my hope is that you will help make sure that there's some accountability here, because the intent of this money is not to just replace another funding stream. So like I said, the agreement was 45% to the state, 55% to the cities and the counties, reporting requirements, and so on. So that agreement then needed to be enabled with legislation. House Bill 4098, we are just incredibly indebted to Representative Sanchez and also to Dr. Richardson for being willing to let us put this enabling legislation into a bill that related to the ADPC. I've put a link to that enrolled bill. There are provisions in that legislation that essentially set up the Prevention, Treatment, and Recovery Board. When I was working on this, I submitted to the legislature an outline of what the provisions in the bill are, because sometimes it's hard to read through legislation and figure out what it does. So I just put the link to that outline in the chat. This Prevention, Treatment, and Recovery Board will determine how these funds are spent. They have to be spent on statewide and regional programs. So really the idea is to look for gaps in our system and ways that this money can be used effectively to address specific issues, in particular that that we see, like where there's a good regional or statewide solution. There's equal representation between the cities and the counties. And then there's additional members that are agreed upon by the state and the cities and the counties on the one hand, so equal between local government and state government, and then agreed upon additional parties. It is co-chaired by one state representative and one local representative. It's organized under OHA, but just like the ADPC, I believe the ADPC is also organized under OHA. It's an administrative thing, right? You all are independent. You get to make your own decisions, but we need an administrative place sometimes for commissions and boards and so on. And so OHA will provide staffing and support, but they will not control the decisions of the board. In that outline I sent, you can see the state members, the city members, city and county members, and then the additional members. I know we're short of time, so I'll just let you take a look at that yourself. The goal is to reach consensus, but if consensus isn't reached, then majority support. There will be public meetings. There will be opportunity for the public to submit recommendations and some public process there. And then let's see here. One of the things that we put into this agreement with the cities and the counties, because we had heard this from so many different experts, was that we really need to improve our data collection practices and evaluating where is treatment happening, where are we spending money, you know, how is that working? And so there is a requirement that some of this funding be used to support support those efforts, but it doesn't specify how much. And so that's something that will need to be decided. And then also the decisions of the board specifically need to be guided and informed by our state strategic plan, which was developed by the ADPC, and any subsequent amendments or updates that you all decide upon. Some evaluation of the efficacy of the allocations, evidence-based strategies and best practices, input from the public, equity considerations for underserved populations, and then it sunsets in 18 years because that's when the money will stop. And any future agreements or any future settlements, the state's portion of any future settlements will go to the board. So next steps, OHA has staff that are in the initial stages of setting up the board. There's a number of sort of administrative tasks that they have to accomplish before things can actually start going. The specific members of the board will need to be selected and appointed, and then the real work will begin. So that is my lightning speed overview, and I'm happy to answer any more questions if folks have them.
And Kimberly, sorry if you said this and I missed it, but Dr. Richardson's on that board, and I assume will be helping constrict the composition of it.
Yes, that's correct. Dr. Richardson is one of the members of the board, and because of the fact that we worked in provisions about the need to be following the ADPC and our state strategic plan, you know, our vision is that the ADPC really has a very and Dr. Richardson have a very strong role in being able to use this money to make decisions that can really address all of the amazing work that you all have been doing for so long to identify, you know, what we need to do and where the changes need to be made. You know, our vision is that the ADPC really has a very strong role here.
Okay, thanks, Kimberly. I'm gonna move us on because we're almost done. Please email any questions to Dr. Richardson. I'm sure we'll get updates from you ongoingly at commission meetings, how it's going. And then Tori and Tony, do you want to give us a little update on the symposium?
Thanks, Kimberly.
Yeah, thank you so much, Kimberly.
Thank you, Kimberly. Good afternoon. Well, an update on the prevention symposium. I think it was a success. We had a really nice turnout. We had over 100 participants throughout the entirety, even after lunch. We assumed, at least I assumed, that we would have more people to leave because they had other pressing things to do, but was pleasantly surprised that that folks stayed engaged the entire time. I do want to say that I know I didn't do a good enough job expressing my gratitude for Dr. Tony Biglin. He played a huge instrumental role in developing that prevention symposium. I mean, just his name allowed for a lot of those presenters to even open the email. He leveraged his connections and friendships to get the creme de la creme to come and present at our prevention symposium, and we are so grateful for him.
Ah, shucks. Did you have more you wanted to say, Tori? Not about me, generally.
So really quickly, I'll share with you guys. Is that you sharing or is that me sharing?
It's not me.
Okay.
I shared it, Tori.
You're sharing it. Okay.
Yep.
Okay. All right. Okay, so it's now gone. I'll just describe it. We did a survey. We asked the people once they left the symposium that they do a survey, and we asked questions in regards to how well they felt the symposium went. And here we go. Can you guys see my screen now?
Mm-hmm.
Awesome. So let me make it a little bigger. Okay, so here are the results from the prevention symposium. We had a Likert scale from strongly agree to strongly disagree. And as you see, the vast majority strongly agreed to the questions that were posed. One of which is, the satisfaction with the event. How likely are they to participate in future events? It's also very high. Satisfied with the speakers. Got over 51% who said they strongly agree. 32%. I'm sorry, 51% say they strongly agree. 40% to say that they agree. Session content was relevant. We had again very high percentage of folks who agreed with that statement. The session content was comprehensive. That was one where we got a little more varied response, and so we can possibly focus on that next time. Can you guys see the new thing that I'm presenting?
It's really small.
Okay, okay, I'll make it bigger. So what we also did was 100%, and I apologize, I have lawn work happening as we speak. I don't know if you guys can hear that. So I also did a survey, during the symposium, we asked what are some future topics that they'd be interested in hearing about, and they were varied, but I tried to categorize them, but again, they were very widely varied. So, but some of the top ones were funding. They'd like to see more information about collaboration, more information about adult prevention, more information about youth in schools, as well as population level approaches to prevention. Finally, we did a SWOT analysis where we inquired about strengths, weaknesses, opportunities, and threats. And the responses from those. With the strengths, a lot of the strengths were really weaknesses. So these are the two answers that were actually strengths, and came up more than once. That we have an amazing history of prevention infrastructure, and that we have great programs here in Oregon. Weaknesses, our top answers were our networking, collaboration, training, advocate silos, stakeholder buy-in, funding, again, lack of alignment, shared vision, and again, lack of adult-specific preventions. I can send out the specifics to you all after the meeting, and you could read through it with a fine-tooth comb if you so wish. Any questions? Tony, you can take it away.
Yeah, I have a few comments. I think that I've heard a lot of positive feedback about the symposium. I think the most important thing that happened was that a bunch of people came together and said, yeah, we need to do more with prevention, and it gets the attention, and we begin to build a network of people, and we have the emails of people, and we can build on that. We can build on that by taking the SWOT analysis and turning it into, here is what we heard, and asking them to confirm or deny things that we got out of it, so that we can begin to shape one of the things that they called for, which was a shared, coordinated vision of what prevention is about, and so on. So I think we can use that to promote prevention. The other thing I wanted to say is that in listening to Kimberly McCulloch's description of the funds that are flowing to Oregon, every time I heard one of those funds, I went, okay, prevention, treatment, and recovery. I think that one of the things that we have not discussed is the lack of funding of the commission itself. We don't have enough staff to do all the things that are needed to do to get, all of the changes that are needed. And I think we should consider that. I don't know if that's administrative funds would be relevant to that, but I think we should take a serious look at the need for more staff, because there's a lot that could be done that we haven't been able to do. And I had a third thing, but I forgot it, so I'll shut up.
Okay, thanks, Tony. And that brings us to the end of our meeting, and and I apologize for not getting to public comment. You can send it to me, Dr. Richardson, or any the other staff. That was my bad trying to get us to the agenda. Hope that there's follow-up and more energy on the prevention front. And when I thought about the opioid settlement money, I was thinking how much of that money is going to prevention as well. So appreciate everybody coming today and participating. Any parting words, Dr. Richardson?
Chair, no, thanks everybody for your time and attention. We've got a lot of work to do, and I think we are starting to get the attention and resources that are necessary for us to do our work. We have our first meeting regarding House Bill 4098, that's now law, on April 12th with the governor's office. So that work that Kimberly talked about will start its organizational meetings next week, or actually in 2 weeks. So stay tuned for more information. And if you do believe we need more staff, this is the right time to actually have that conversation. Because administratively we're housed in OHA, their POP and LC process is beginning. So that's something that you should share with the chair, and then we can work to discuss that. Sorry we're so rushed today, but I thought every agenda item was important for us to get to our work. So again, thank you for your service, and I look forward to being able to see you next month, which I hope will be in person. So stay tuned.
All right, thanks everybody.